Hello, I'm Sue Pavord. I'm a consultant haematologist in Oxford. Thanks very much to Mervyn and colleagues for allowing me to present today. And I'm going to talk about ITP management during the COVID-19 pandemic and the results of a national audit that we've been running over the last 12 months and closed last week. So a year ago, last April, when the pandemic was in its early stages, we produced a practical guidance for how to manage patients with new or relapsed ITP. So why did we do this? Well, this followed a WHO recommendation to avoid steroids where possible during the pandemic. And this was based on meta-analyses of steroids on the outcomes of people with SARS or MERS, previous similar viruses to our coronavirus now. And the study showed that there was no survival benefit of using steroids, and there were several adverse effects, ones that we're very familiar with: avascular necrosis of the femoral head of the hip, psychosis, diabetes, secondary infections, and furthermore there was evidence of delayed viral clearance from the lungs. In addition to that, some observational studies of flu have shown higher mortality in patients receiving steroids. So this is a problem for us in ITP because we use a lot of steroids. In fact, we use too many steroids. And we tried to address that in the updated international consensus guidelines that were published by Drew Proven and international group of us in Blood Advances in 2019. And to try and avoid overuse of steroids, we recommended that if 1 milligram per kilogram is given as a starting dose, the maximum dose should be 80 milligrams, regardless of the weight higher than that. And the maximum duration of that dose should be 3 weeks. If there's a good response, then the steroids should be tapered and stopped by 6 weeks. And if no response within 2 weeks, to taper and stop quickly over 2 to 3 days. The idea being to avoid long courses of steroids. So our recommendation really supported that, certainly during the pandemic, to avoid steroids where possible in early COVID-19 disease or where there is no COVID-19 infection yet. But we considered that COVID-19 is associated in its severe form with a big inflammatory element and this big cytokine storm. So we considered that it might be important to use steroids for patients who are hospitalized with severe COVID-19. And in fact, this was subsequently borne out by the recovery study, which was a study of low-cost steroids in hospitalized patients with severe respiratory complications of COVID-19. And they randomized over 6,000 patients between dexamethasone, which is a steroid, and the usual care in a 1-to-2 randomization. And this dexamethasone used was 6 milligrams daily for 10 days. The outcome they looked at was the 28-day mortality. And they found that in patients needing ventilation, steroids dropped the mortality by 1/3. And in those just needing oxygen support but not ventilation, it dropped mortality by 1/5. But there was a suggestion of a negative effect if given in patients with less severe COVID infection. And this was published earlier this year. So the WHO recommendation in September 2020 really confirmed their earlier recommendation. They said that don't use them in the treatment of non-severe COVID or in patients who have not yet got COVID, as treatment brought no benefits to this early COVID group and could prove harmful, but do use them, dexamethasone, for the treatment of patients with severe and critical COVID-19 disease. So we can extrapolate that recommendation to our patients with ITP. And indeed, long COVID may itself be made worse by steroids. If you consider the effects of long COVID, their fatigue, myopathy, psychological and psychiatric symptoms, all the things that steroids can increase. And this meta-analysis of 21,000 patients with COVID-19 showed that there were worse outcomes with steroids, even with short durations of 3 to 12 days. So this is all really important to consider when we're trying to manage ITP patients in the context of this pandemic. So if we can't use steroids first line, what else have we got? Well, we have the TPO and the Thrombopoetin receptor agonists, and we have the fostamatinib, which is a new drug on the scene, recently licensed, which blocks the clearance of platelets by the spleen, by the macrophages in the spleen. We've got rituximab, but again, that is an immunosuppressant and one that we might want to be avoiding during the pandemic. And then we have these older style medications where there is less robust evidence, but we've certainly found good responses to mycophenolate in the FLIGHT trial. But again, it is an immunosuppressant and one we might want to avoid. So just looking at the thrombopoetin receptor agonists, the main ones are eltrombopag and romiplostim in the UK, and avatrombopag is much more new. So they bind to the thrombopoetin receptor and they increase this platelet signaling to produce more platelets. And although at the moment they were licensed for use after 12 months of ITP, romiplostim has now gained its license for early use. And this is based on some good studies here. And you can see the success rate of romiplostim in the first year of use. So 83% success, 86% response, 80% response. So very good efficacy, good response rates with romiplostim. And equally with eltrombopag, which has been shown to have good responses in managing patients and preparing them for surgery. So patients with low platelet counts given eltrombopag in preparation for surgery, there was 82% response rate. So with this in mind and the need to prevent use of steroids where we can, the NHS England have been really supportive of our recommendations, and they issued an interim statement to say that thrombopoetin receptor agonists can be used as first-line therapy for new or relapsed ITP during the pandemic. So this is off license, but we are in unprecedented times, and it's important that we are really considering what is the safest management for ITP patients during the COVID pandemic. And in patients who are hospitalized with COVID, we might want to avoid thrombopoetin receptor agonists because they can potentially increase the risk of thrombosis. And we know that COVID is associated with small, tiny thrombosis and blood clots within the capillaries lining the lung pockets, the alveoli, and also larger vessel clots like in deep vein thrombosis and pulmonary embolism. So we don't want to exacerbate that with thrombopoetin receptor agonists. And in these patients, there has been shown to be good benefit with steroids, as I have alluded to before. And what we have shown in the laboratory is that thrombopoetin receptor agonists can stimulate some prothrombotic or pro-clotting status of the blood, although the increased risk seems to be very, very tiny in practice. What about intravenous immunoglobulin? Can we use this during the COVID pandemic? Well, these studies have been very reassuring and actually shown some benefit of using immunoglobulin for patients with COVID. So that's helpful to know when we're considering how to treat patients with ITP. And for patients with chronic ITP, we just suggest continue the usual treatment. Don't rock the boat, but with hospital avoidance strategies that many patients will be very familiar with now, so online video consultations or telephone consultations, deliveries from pharmacy out to patients' home, and a lot of patient support and information, or hopefully patients feel that they have received this, and advice regarding shielding. What about the virus? What's been our advice with the vaccine? What's been our advice here? We're concerned about a potential for ITP relapse or a new presentation. So for patients to be looking out for new signs of bleeding or bruising, and then to report anything that does occur so that a platelet count can be checked. Potentially an impaired immune response in those who are on steroids or immunosuppressants. They may not get such an immune response to the vaccine as we would like. And there hasn't been much in the way of bleeding at the vaccine sites, but it is an intramuscular injection, so we do ask for compression for a good 2 to 3 minutes at the vaccine site to avoid bleeding in patients who have a low platelet count. And also there have been some nosebleeds in patients taking their high PCR swabs if their platelet count is low, so that's something to be aware of as well. So just coming to the audit then, this audit was started a year ago, and it was to look at new or relapsed patients with ITP between the 1st of March 2020 and the 1st of March 2021. And it was managed through Oxford, so my 2 registrars set it up, and with the support of the UK ITP Forum and the ITP Patient Association and HemeStar, the registrars, hematology registrars who help with audits. This is the start of the electronic link. It was very easy to enter patient data. It was all anonymised. There were no patient identifiers whatsoever. But we were able to get a good analysis of what the management had been, how patients had responded, and whether there had been any resistance or increased refractoriness to treatment. And there were very many centres contributing to the audit. So of 343 entries, 318 patients had needed first-line therapy. And so, as we know with ITP, in many cases, it just doesn't need treatment. So it may be that there's some reporting bias here, that it's the ones that do need treatment that are in the minds of the clinicians and get reported onto the audit. So the majority did have steroids. There was still some difficulty getting hold of the thrombopoetin receptor agonists. And of course, this spans the whole year, whereas it wasn't until later in the year that NHSE confirmed their support for using thrombopoetin receptor agonists up front. So we had 189 patients who received steroids as first line, just over, so about 45 who received intravenous immunoglobulin, 47 who received thrombopoetin receptor agonists first line, and then a mixture of other different medications, including rituximab and mycophenolate. So these were the baseline characteristics. So 335 patients here in total. They were, you can see here that 64% were new diagnoses and 36% were relapses. You can see the first-line treatments that were used, the age range, and this is the median age was the same across all the treatment groups, and the male to female ratio was also, it was 50-50 practically across all the different groups. The secondary ITP tended to be treated more with steroids, perhaps not surprising, because many of those were underlying autoimmune disease, and steroids would be a better treatment for patients with underlying autoimmune disease because it can kill two birds with one stone, treat the ITP and treat the underlying autoimmune disease, whereas the thrombopoetin receptor agonists would not treat the underlying disease. And you'll see here, sorry, the post-vaccine that the TPO more thrombopoetin receptor agonists were used post-vaccine ITP. For the TPOs, most of the use of thrombopoetin receptor agonists was for relapse disease as opposed to new diagnosis. So what were the indications for treatment? So again, if we look at the overall group, about half of them, it was because of a platelet count below 20, and almost all the rest because of bleeding symptoms or risk of bleeding. A few because of the need to start anticoagulation, maybe because of atrial fibrillation or deep vein thrombosis. And then just 2 patients because of fatigue, and 3 patients because of needing to have surgery or a procedure or a childbirth. And then 3 patients because of concurrent autoimmune hemolytic anemia. And in the steroid group, we can see, in fact, all the groups, we can see it's fairly similar. About half the cases were because of low platelet count of less than 20, and a good proportion because of bleeding symptoms or at risk of bleeding, and then a few because of the need to start anticoagulation, and this was higher again in the thrombopoetin receptor agonists. So if we look at the background for those patients who had secondary ITP, I thought this was interesting just to see the underlying conditions. And there are a huge range of conditions, but the ones that stick out perhaps are the low-grade lymphoproliferative conditions, so low-grade lymphoma, some HIV, and then antiphospholipid syndrome. So antiphospholipid syndrome, we do see ITP as well. And SLE, of course, was the most common, but the most common that was really interesting for me was actually post-vaccine. And this is particularly important if we consider that we only started vaccinating at the end of 2020, and this audit encompasses the whole year. So that's a significant amount. So what about the patients who had COVID infection? So out of the 343 studied, 23 had a positive COVID test. They were, the range of having COVID symptoms around the time of ITP diagnosis was -2. So the -2 day of COVID symptoms, ITP was diagnosed, to +60 days, and the median was 12.5 days. So 12.5 days of COVID symptoms when the ITP was diagnosed. 13 of our 23 patients had an inpatient stay, 5 needed intubation because of ventilation, and 9 were managed as outpatients. Now let's look at the vaccine, because this is, I thought, very interesting. So the Pfizer vaccine, 66 patients of the 343 had Pfizer vaccine, and 14 of those had pre and post vaccine platelet counts done, because we hadn't recommended that they would be done, so it's not surprising that there weren't many done. And you will see from this that only 1 of the 14 dropped their platelet count after Pfizer vaccine. Almost everyone stayed stable, and 1 person increased their platelet count. And this is in contrast to the AstraZeneca vaccine. Of 107 patients received the AstraZeneca vaccine, and 16 of those had pre and post platelet counts checked. And you can see that in nobody, or just 1 person, the platelet count remained stable. Half of the 16 dropped their platelet count, and half of them increased their platelet count. So I think that shows the immunogenicity of, that can stimulate inflammation or autoimmune disease, potentially with the AstraZeneca vaccine. But we don't know what happened to the other, how many is that, 90 or so, 94, 91 patients who received the AstraZeneca vaccine. They didn't present with symptoms, they didn't present with bleeding or bruising. So it's probably fine for the majority of cases, but it's just useful to know that it can make the platelet count go up or down. And therefore, if you have the AstraZeneca vaccine, it may be worth doing a post-vaccine check of your platelet count to see what has happened. But we haven't come across any major incidences with the vaccines and ITP patients. So what about the effect of the various treatments? So this was preliminary results because I haven't had time to analyse the whole 343 yet. But we looked at these when we were halfway through the study, or when we'd had this number a couple of months ago. And we found that the response rate for those receiving 1 milligram per kilogram of prednisolone was 63%. It was 60% for those receiving a lower dose prednisolone. So that was reassuring, this lower dose prednisolone. Those receiving thrombopoetin receptor agonists up front, it was 85%, and 16% for those receiving intravenous immunoglobulin. So this was much lower than we would have expected. So we just need to check that with the analysis of the bigger number. The timing of response, the majority responded within 7 days. So that was a really fantastic response. And 12, we had no follow-up data. So I thought that was very interesting, and it will be good to see the final analysis when we've looked at the 343 cases. So in conclusion, the management of new and relapsed ITP needs careful consideration depending on the state of the pandemic at the time. Centres have been able to use upfront thrombopoetin receptor agonists during the pandemic to avoid steroids. Upfront thrombopoetin receptor agonists have had excellent responses. And COVID-19 vaccine may potentially increase the risk of new or relapsed ITP. And this is something that we need to be monitoring. And indeed, we are monitoring and potentially looking out for in individual patients and repeating platelet counts if there is concern. Thanks very much, and I'm happy to answer questions.